Bismillah ar-Rahman ar-Rahim. I begin in the name of Allah, the most gracious and the most merciful. Good morning to some of you, good afternoon to others, and assalamu alaikum to all of you. Thank you very much, Professor Hussain, Nusrat to me, for such a warm and glorious introduction. I'm really humbled. You've been very, very kind. It's been a wonderful journey that we have shared over the last 3 decades, alhamdulillah. And thanks to this global mental health and cultural psychiatry group, being a part of it, we've had the pleasure of organizing these meetings for the last many years. I'll today be talking to you about this fascinating journey on suicide prevention, from evidence generation to policy development. So we're going to keep with the theme that Professor Hussain spoke about. I've not been given much time. It's, I believe, only 45 minutes. So we'll try to keep within that. Okay, my disclosures. Next. Samin beta, next slide. Okay, so I'm going to take you through this journey, and just to give you an idea, we're going to go through a background. Most of you would be familiar with it already. Then we'll talk about our process of evidence generation, the work that has been done, the work that is going on. Then we'll move on to community engagement and involvement, dissemination, and finally end on policy implications and where has it taken us its journey. Next slide, please. So, suicide and attempted suicide, most of you are aware of this, are serious global health problems. It is a major challenge to public health. Worldwide, almost 1 million suicides a year, 1 every 40 seconds, we all know about it, 10th leading cause of death overall. And in the youngsters between 15 to 29, second leading cause of death. And most of these deaths are actually 80% are in the low and middle income countries. Over the last 45 years, the rates of suicide have grown by almost 60%. Now that is significant. With each suicide, almost 60 people are affected and 165 people in a lifetime. So keep these numbers in mind. And why are we kind of embarking on this journey, and what difference we want to make? Next slide, please. Samin beta, next slide. Thank you. So Pakistan, as we know, most of the people joining here are from Pakistan. It is a low and middle income country. We're one of the most populous countries in the world. 5th or 6th largest largest country in the world. Unfortunately, the literacy rates are quite low, almost 35 to 40%, and a third of population actually lives below the poverty line. And there's such a disparity between haves and have-nots. Rich are getting richer, and poor, unfortunately, don't even know where their next meal is going to come from. 2/3 of the population is below 35, hence increasing the significance of our work in self-harm and suicide prevention. For such a large country, we've got a fairly small number of people who are registered, who are of recognized number of psychiatrists and psychologists that cannot cater to the needs of this population. I'll be mostly talking to you about the work that has been done in Pakistan. Next slide, please. So, self-harm and suicide in Pakistan. It's understudied and under-researched subject. There are actually no official data on suicide rates. Most of the information is available through newspapers, media, colleagues. The challenging part is, and the sad part is, that suicide is still a criminal offense under the Pakistan Penal Code, punishable by fine or prison or both, and hence it's obviously massively underreported. This brings along stigma, shame, and unfortunately also police extortions and other challenges. Next slide. Now, the work is going on to address this disparity and this gap. In 2001, Mental Health Ordinance actually proposed a change where it proposed that suicide, people who try and commit suicide, they should actually be assessed by a mental health professional, a psychiatrist, and if deemed to be suffering from a mental health problems, then accordingly offer treatment. Since then, the Sindh, Punjab, and the Khyber Pakhtunkhwa assemblies have actually enacted a mental health legislation. This was also passed by the Senate in 2018. However, by the time it went through this process, the assemblies got devolved. But there's been more work at the National Assembly level, which I'll talk about later. However, at this point in time, Pakistan is still one of the few countries in the world in which attempted suicide is still a punishable offense. So the challenge massively remains. Next slide, please. So we are going to go through some evidence generation, the work we have done. Next slide, please. To set a context, WHO's Mental Health Gap Action Program in 2008 recognized self-harm and suicide as a priority condition. It says that there's a wide gap between available health system and capacity and resources. It highlights what is urgently needed and what is available to reduce the burden. It says that 1 in 10 people have mental disorder, but unfortunately only 1% of global workforce is provided with mental health care. Then in 2018, WHO identified preventing suicide as a key priority, and preventive interventions among vulnerable populations were prioritized. This is around the time when our work on suicide prevention also began, and we published our first paper. So if you can go to our next slide, please. Now, when we look at prevention, a number of interventions, psychological interventions, cognitive behavioral therapy, problem-solving therapy, interpersonal forms of psychotherapies, there's evidence around them having beneficial effect in people who attempt self-harm or who attempt suicide. Now, problem-solving therapy is what we focused on. It's also been identified and prioritized by the National Institute of Clinical Excellence in NICE guidelines. It's brief, cost-effective, and pragmatic intervention. But what do you do when you pick up an intervention from the West? Do you just pick it up and bring it across and implement it? No. Nusrat talked about it. One of the major work that has been done through Nusrat, through Pakistan Institute of Living Learning, University of Manchester, is about cultural adaptation of these programs, which refers to modifications that are made culturally sensitive and tailored to the cultural group's traditional worldviews. And the aim is to generate a culturally equivalent version of the treatment intervention. So, next slide. Next slide, beta. Samin, beta, we are a slide behind. So, yeah, thank you. So, next slide, beta. Samin, beta, yeah, thank you. So, our exploratory trial, we started working on it on 2011 and published in 2014, the same time where WHO recognized, prioritized self-harm and suicide. This was an exploratory study to determine the effect of a brief psychological intervention, which was culturally adapted to reduce the suicidal ideation in individuals presenting after a recent episode of self-harm. Professor Caroline Chugram, our esteemed guest speaker, who's a great friend of Pakistan, will be talking about the intervention and the qualitative work later. Next slide, please. So we recruited 221 patients from 3 public hospitals in Karachi is one of the largest cities in the world and the largest in Pakistan. Half of these 221 received the intervention, other half were treatment as usual. Our outcome measures were reduction of suicidal ideation, depression, and hopelessness. Next slide, please. So, the assessments were done at baseline and at 3 months. And then 3 months following finishing of the intervention. So it was to see if the effects of intervention can be sustained. So it was just not about exit kind of interviews. Now I'll present some basic characteristics. Despite the majority of people coming from actually a low-income setting, the majority, 80% had interpersonal problems. You would expect it that from people coming from, next slide, Peter, Samin. So my apologies. So for this gap in the slide. So majority of people came from low-income settings. However, and you would have expected that financial constraints be to the main kind of resource or main source of stress for them to be attempting self-harm episodes. Actually, it was not. It was more around interpersonal problems, hence fueling our notion or supporting our notion of it, problem-solving strategies. Almost 90% did not tell anyone, and more than 90% did not leave a suicide note. So the challenge is to make them resilient and to deal with these interpersonal problems. Next slide, please. Now, despite 90% concealing their suicidal thoughts, 75% had extreme to extremely severe suicide intent. So this even kind of makes the task more difficult and more challenging. And pesticides and toxic chemicals were used by more than 90% of people, which is fairly universal. Looking at the results, we were actually next slide, Peter. So our results were very encouraging. We found significant improvement on our assessment scores, particularly the PEC suicidal ideation, the hopelessness and depression score, the coping resource inventories, and the quality of life. Now, the key is that these effects were sustained even 3 months after finishing the intervention. So it was just not that assessments were effective while the intervention or the end of an intervention, they were sustained 3 months after the intervention. Next slide. So in summary, we got some positive results, and this then led to embark on thinking about what can we do next. Now, next slide. One of the kind of limitations of our study, our exploratory study, was that small sample size, and then it was a hospital-based study, follow-ups were short, and we were not powered for repetition of self-harm. So now we applied to Medical Research Council for a much larger and countrywide study across Pakistan, and also looking at recruiting from the community and the hospital setting both. So this was conducted in 5 major cities of Pakistan. Next slide, please. We recruited patients from Karachi, from Lahore, Rawalpindi, Quetta, and Peshawar. The settings were community and the hospital. Assessments were done at baseline, 3 months, and then 3 months after intervention, 6 months after intervention, and 9 months after intervention. So the study period was 12 months, and there was qualitative work done as well, which will again be will be talked about by Professor Chaudhry. We recruited 901 participants. Next slide. For me, one of the achievements, one of the key work, which is a testament to me of the hard work that the PIL researchers, field workers did, was the retention rate of 94%. So we screened about 4,000 people, randomized 901, and retention rate at the end of 12 months was 94%, which is And remember, this is considered to be a difficult group to keep in trial. Next slide, please. Looking at the social demographics, more than 95% of participants were from ultra poor, poor, or low middle class group. 2/3 had not even completed their schooling. A large number of them were unemployed and relatively less than, slightly less than our exploratory trial. Next slide. 75% of the subjects had ingested pesticide and toxic chemicals, and again, less than our exploratory study. Next slide, please. Now, once again, despite 95% of people coming from low income setting, the majority of people had problem with interpersonal communication. Interpersonal problems were the leading cause of leading to deliberate self-harm, followed by financial difficulties. Next slide, please. In 98% participants, it was their first or second attempt. 65% did not tell anyone that they wished they were dead or contemplating suicide, and more than 60% had a definite or serious intent. Next slide, please. So looking at the clinical characteristics, 65% scored moderate to severe depression, 96% had moderate to severe hopelessness, which, as you know, is a strong predictor for suicide. And nearly 60% scored high on suicidal ideation. Next slide, please. The intervention group showed significant improvement on Beck's suicidal ideation and Beck depression scores. Now, even more important than just the improvement at 3 months is that this improvement was sustained not just at 3 months, but 6 months, and even at 12 months. Remember, it's very easy to offer intervention, but what do you leave behind? What impact do you leave behind? And I think that's the critical evidence that is required. We did not see any change in the hopelessness inventory. Next slide, please. There was a significant improvement in their quality of life scores, which was sustained again for 9 months after the intervention. Next slide, we saw significant improvement on the client satisfaction questionnaire and the coping resource inventory, again sustained over 12 months. So in summary, we got significant improvements of key clinical outcomes. But remember, we talked about, one of our aims was to look at repetitions. Now, we didn't get a significant difference in the repetition of self-harm between the two groups. However, numerically, in the intervention arm, fewer number of participants repeated self-harm in comparison to the treatment as usual, maybe because it requires a much larger sample to reach that significance. We also got to keep in mind here that a third of the sample was community-based and 2/3 was hospital-based in comparison to 100% of sample in the previous study being hospital-based. Next study. Now, this is a very interesting stage. While conducting these CMAP studies in adults for the previous 2 ones, there were a number of participants, about 250 of youngsters that were below 18 years who were excluded, and they wanted help. Hence, based on their need, we were inspired by our participants to apply for another grant. This time, we went to MRC, similar kind of project, but for 12 to 17 years old. Again, the chief investigator for the study, Dr. Professor Hussain, myself and Professor Naseem Chaudhry as co-investigators. Next slide, please. This study is being currently conducted, again in 5 major cities of Pakistan: Karachi, Lahore, Rawalpindi, Multan, and Hyderabad. Next slide. So this is again over 12 months, both in community and hospital settings, and also we are taking self-referrals. The assessments are at baseline, 3 months, 6 months, and 12 months. So far, we have randomized about 271 participants. We're also doing qualitative work in this study as well. Next slide, please. Now, there's another study which is very interesting that I want to share with you. This is the CPAC study. It's a feasibility study for research capacity, research capability and trial readiness in Pakistan in school-going children. So this is about schools. The task of self-harm and suicide prevention in youths is huge. So this study is targeting this population. It's been conducted in schools and along with students, teachers, and health professionals who are based in schools. And the idea is to examine the feasibility and acceptability of these 3 preventative interventions in this study. Next slide, please. Now, both Professor Hussain has talked about it, and take pride in capacity building, capability and capacity building. So along with the UK, India and Pakistan, we were successful in a fairly large GCRF grant, South Asia Self-Harm Research Capability Building. I'll be talking to you about, it's an ongoing study, I'll be talking to you about the South Asia Harm Reduction Movement, SEHR-M, that we are doing in Pakistan. Next slide, please. The aim of the study is capacity and capability building, both in Pakistan and UK, in the global mental health research. Evidence synthesis is to bring together all relevant information on self-harm and suicide and to identify treatment gaps in knowledge, establish evidence base and best practice, conduct household survey across Pakistan to understand social determinants of suicidal behavior and suicide in Pakistan, and also evaluation of hospital and community and prison healthcare self-harm episode and the routine data. Look at that as well. And remember, so we don't have currently routine data and registers. Next slide, please. Okay, sorry. So we're also doing qualitative interviews with key stakeholders, including clinicians, GPs, policymakers, and medical legal officers and religious leaders and scholars. Remember, you cannot exclude them to keep things on board. Designing and developing protocols for feasibility intervention studies, keeping COVID-19 in perspective, and finally to disseminate the research finding and strengthen the impact of project through knowledge exchange processes. Next slide, please. So these are the studies. Now comes the second part, or the excitement of the work, is community engagement, involvement, dissemination. We've been disseminating across countries, in low resource communities across Pakistan, in schools, colleges, universities, involving participants in design and planning studies. We've focused on trial steering committees and DMACs. In fact, when we first embarked on our intervention studies, myself and Nusrat and our group, we actually, even ethics committee were in very much a preliminary stage. We take pride in being instrumental in formalizing the ethical process of studies in Pakistan. Next slide, please. For public awareness, poster competitions were held across Pakistan, and we received some absolutely fabulous and exciting entries. And you could go to Bill's website and you'll be able to see a lot more in detail. And you know, there were some outstanding and inspiring thoughts behind these posters. We had a call, next slide, for short films on self-harm and suicide prevention, which was again very successful. We got some phenomenal videos. Again, they're available on Bill's website. It would be worth seeing them, how they depict true stories, and these are based on true stories. So next slide. This is something I'm so proud of. Our own Dr. Mina Hussain She's produced some brilliant short films on mental health issues from Pakistan. Dia, which is a short film about psychosis. The other one is Stray Dog, Come Out at Nights. It's a story about a male migrant sex worker. These have been shortlisted for international festivals. They won awards, acclamation, some absolutely fabulous and fascinating work. Next slide, please. So, since 2015, we've been involved with global mental health and capacity and capability building work. Around the time when it started becoming difficult to take people to the Western world, especially to UK for training in capacity building, we started training these global mental health capacity capability meetings in UAE, Sharjah. And we've held meetings every year since then, and twice in 1 year on one occasion. And we've been very fortunate to have some very, very supportive colleagues like Christine Ferber, Professor Beldeacon, Professor Atif Rahman, Aminia, Jim McCrory, Amy, and Professor Don Edge, who have given their time, who've given their expertise in training people and developing capacity. And this work has been extremely, extremely rewarding, and we are very grateful for their input. We've also been busy in developing promotional materials, not just in English and Urdu, but also in regional and provincial dialects like Pashto, Punjabi, and Sindhi, which are disseminated across the country. Next slide, please. We've been invited by the International Association for Suicide Prevention for 2 years in a row to translate their brochures for international conference in Urdu, and we've the privilege of doing that. Next slide, please. Every year on Suicide Prevention Day, we hold activities across large and smaller cities of Pakistan. And this goes on every year for last 4 years in a row now, and with some very active participation. Next slide, please. We've been busy. Our team, our colleagues have been busy on the media as well, talking about its sensitivity, which is important, using every opportunity, such as Mental Health Day, Mother's Day, Suicide Prevention Day, World Suicide Day, whatever comes. Whenever there's a mental health awareness event, we would take advantage and raise awareness through media campaigns. Next slide, please. Our dissemination has been going on at all levels, not just local and regional, but national and international meeting, where senior, junior colleagues have been participating and presenting the work actively. Next slide, please. Now, another very exciting part. Developing suicide first aid guidelines for Pakistan. This is the very first. We are very, very grateful that this has been done under the supervision of Aminia Kaluchi. We had our first meeting in Sharjah, UAE in 2018 to develop these guidelines for members of public providing first aid to persons in Pakistan who are experiencing suicidal thoughts or displaying suicidal behavior. No study of this kind has so far been done in Pakistan. So this is definitely a first one. We've got the ethics approval locally, and I think the Manchester one is awaited. Next slide, please. Now, Nusrat talked about this evidence synthesis earlier as well. We take really pride in our youngsters leading this work on evidence synthesis, systematic reviews. 2 of the systematic reviews are already published. Some of them actually receiving recognition already. And as you can see, these are our colleagues, Usman and others who are very much in the lead authorships in these studies. And 12 more actually are in the pipeline, 12 more, which is incredible. Next slide. Now, to policy implications. Next slide. So this part of journey, it was inspired by Professor Hussain again. And along with him, Professor David Kingdon. They flew from England. They met with Mr. Riaz Fathiana, who's an M&A member of National Assembly and a chairperson for National Assembly Standing Committee for Law and Justice and the convener for National Parliamentary Strategic Development Task Force. They highlighted to him our work and research work on suicide prevention and self-harm reduction in Pakistan. He was absolutely magnificent. He got on board and joined hands, and there's been no turning back since. So next slide. With his collaboration, we then organized a Pakistan National Suicide Prevention Strategy meeting at the Royal College of Psychiatrists in London. Some illustrious participants in this, Professor Lewis Appleby, the former mental health czar, presided this and who's currently lead for the Center for Mental Health and Safety and Investigating Suicide and Self-Harm Center in UK. Mr. Riaz Fathiana flew from Pakistan. Professor Hussain was there. Leading psychiatrists from Pakistan, like Professor Maudat Rana, Professor Farid Minhas, Professor Naseem Chaudhry, our own, and also Pakistan Psychiatric Society's current president, Professor Imtiaz Doga was there, and many other leading clinicians from UK and the Royal College participated in this first meeting to develop this suicide prevention strategy for Pakistan. Following this, on the 1st of October in 2019, next slide, thank you, Samir, Mr. Riaz Fathiana presented a bill in Parliament to decriminalize self-harm and suicide. Now, this again is a landmark day and date. So this work is now in progress. And inshallah, over a period of time, you'll hear more about this. Next slide, please. Then, along with the Parliamentary Task Force on Sustainable Development Goals, which is Dr. Mr. Fathiana's lead, Pakistan Institute of Living and Learning and University of Manchester, a mental health question time was organized in March of this year, just before the COVID erupted in Pakistan. This was at the Arts Council in Islamabad. The question time was attended by more than 100 people, and we had an experts panel with members from UK, Canada, USA, Pakistan, and they addressed the participants' question. And the idea was for developing mental health strategy for Pakistan. Next slide, please. As Nusrat mentioned, we then had the pleasure and the honor of being able to organize the first all-parliamentary mental health summit 2020 on the 12th of March, which was organized jointly by the SDGs, the Parliamentary Task Force, the Pakistan Institute of Living and Learning, and the University of Manchester at the President House, hosted by the President. This was just incredible. And the purpose was to develop a comprehensive mental health strategy for 2020 to 2030, which should help us in Pakistan to meet the United Nations Strategic Development Goals. The inaugural session was attended by the President, and the best part was that at the end of the event, the PIL and University of Manchester were tasked to make policy guidelines for legislation and to develop the first Pakistan health policy in consultation with key stakeholders. Now, next slide. So the process of involving key stakeholders began. We started having meetings. This was the following day at the Institute of Parliamentary Services, discussion groups, and we adopted, to develop this strategy and guidelines, we developed a life course. We adopted a life course approach from preconception to older adults. And next slide, please. And we aligned these to the strategic development goals. Why mental health is included in strategic development goal 3, there's a strong evidence that supports that social factors being strongly related to mental health, including relationship issues, poverty, and migration, which directly affects prevalence and severity of mental disorders. Now there is an evidence that 13 out of 17 SDGs are closely related to mental health. Okay, how am I doing on time, Samin, so far? I hope it's okay. I think I still have time. Okay, so
You
now,
still have 10 minutes.
Good. So we've now come to the second stage of this process, where discussion groups have started to help develop Pakistan mental health strategy and implementation roadmap. So far, 2 sessions have been already conducted. The preconception and pregnancy ones, and the older adults. 2 more are to be conducted by the end of this month. The idea is that by the end of 2021, we have an outline ready to be able to present to the Parliament and share it with them. Next slide. Now, this is my penultimate goal, is to share a clip from Mr. Riaz Fatiana, speaking in one of the groups for this strategy development groups, which I would like to share with you. If we can please play this clip.
So, if you remember, we were together in London last year in 2019. That was a wonderful event organized by you people, and I presented there a paper on mental health. Today, this is a pride for us that we all are together again, because state of mental health is very important in this country, you know, especially post COVID-19, and even not post COVID, still situation is going on, and there is another threat that we may increase patients of COVID-19. During, if you remember, during a London session, there was a conversation on suicide and after effects. Previously in Pakistan, at present, our law is very outdated, and if somebody survives, then police is ready to capture him or her. So I also moved a bill in amendment that rather than to please arrest the person who is also ready to die, and he should be sent to jail or in prison or in police station, it's really better that he should be referred to a counseling center to give him psychological and social support and community support and family support. Anyhow, with passage of time, we hope due to your technical and moral and comprehensive support, Pakistan's parliament is working on this.
Thank you very much, Sameer. Next slide, please. So, now finally, this incredible journey of putting Pakistan flag on the world map in mental health. It's really been an exhilarating journey, from an exploratory study arising from a significant global health challenge to leading to possibly the largest psychological intervention study in self-harm and suicide, leading to community engagement, dissemination, linking up with key opinion leaders and decision makers, policy makers, and then this capacity and capability work, leading to capacity capability building grant, working on national suicide data, working towards developing guidelines, suicide prevention guidelines, and then being asked to develop the mental health strategy and policy. This is for an academic, a clinical academic, this is actually a dream come true. Now, none of this would have been possible without the valuable support of our participants. A brilliant and inspiring peer team, who it's a pleasure to work with, are very, very supportive and relentlessly pursuant collaborators, research colleagues across the world, and of course, these prestigious funding bodies who have continued to have faith and confidence in us and support us in work that we've been doing in Pakistan. And lastly, thank you very much for providing me this opportunity today to present this part of the journey of PIP. Thank you.